Hello and welcome to another question and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel. I'm your host for the show today. Welcome to the show. Also want to welcome anyone that's watching this on replay. If you have any questions today, please type them into the chat pad, or you can also come on live on the show. And you can come on live on the show if you click on this link here that I've just posted in the chat pad. I want to welcome all of our viewers on LinkedIn, YouTube, Rumble, Twitter, Facebook, and X. Now, what makes me qualified to put on a show with questioned families families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background, having worked in critical care for nearly 25 years in 3 different countries, where I also worked as a nurse manager for over 5 years. I have been consulting and advocating for families in intensive care since 2013 at intensivecarehotline.com. We have saved many lives with our consulting and advocacy, and you can verify that at intensivecarehotline.com on our testimonial section, as well as on our podcast section at intensivecarehotline.com, where we have interviewed clients directly. I am also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are sending critical care nurses and intensive care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, but also for otherwise medically complex adults and children at home, which includes home BiPAP, home CPAP, seizure management, home TPN, tracheostomy care when adults and children are not ventilated, also IV infusions at home, including IV potassium, IV magnesium, etc. With Intensive Care at Home, we are providing a genuine alternative to a long-term stay in intensive care. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in regional and rural areas. Now, without any further ado, let's go to the first question. Just one more thing, or again, housekeeping. Type your questions into the chat pad, or connect with me on the StreamYard link live, and you can talk to me live on the show. Also, if you want to make a small donation and you want to get a super chat, you're welcome to do that, and then I will get to your question straight away. That helps us creating as much content as possible for families in intensive care, and really help as many families in intensive care as possible, or with Intensive Care at Home. Your small donation will go a long way. Also, if you appreciate the work that we are doing, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button, click the notification bell, comment below what you want to see next. Once again, also, if you want your video done as quickly as possible, make a small donation to the super chat and I will get a video done for you specifically. Now, in the meantime, let's get on to our first question. And also, when I read out the questions, they are going as far back as October. So that's how many questions we are getting. And that also, for you knowing that if you want your questions answered, either contact us directly at intensivecarehotline.com or intensivecareathome.com, or if you want your questions answered quickly, I will get to them regardless, but if you make a small donation, I will get to it quicker. Okay, so let's read out the first question, which is coming in from Billy. And Billy says, "Hi, Patrick. My wife is in intensive care and she has been hard to sedate. Her vital signs are good, but they're keeping her heavily sedated to keep her calm, and this has been the 4th day on the ventilator. What should we be looking for, and what should we be doing?" Thank you, Billy, for your question. So sometimes patients in intensive care are hard to sedate when they are ventilated with a breathing tube. So I don't know, most of you watching this would have seen a breathing tube by now, most likely. And what that looks like, it goes into the back of the throat. It basically pumps air into the lungs, extremely uncomfortable. It can be very painful, which is why patients end up in an induced coma, why patients end up sedated and on opiates. And that can be a big challenge because an induced coma comes with many undesired side effects, right? And it's good that your wife's vital signs are stable. That is really good. And the question here is, Billy, why is your wife on the ventilator? You haven't shared that. And it is so important that when you write an email like that, that you give us as much information as possible, because there's many reasons why your wife might be in an induced coma. It could be a pneumonia, it could be a heart attack. She could have Guillain-Barré syndrome. She might have had a stroke. She might have had a traumatic brain injury. We don't really know what the reason for your wife's intubation and induced coma is. So once again, the more information you can give us when you write in, the better. Now, question is, why are they keeping her heavily sedated? Sometimes it's good to keep patients in an induced coma for a few days, because they're simply very sick. They're critically ill. Their body needs to rest and heal. The last thing you want for your wife is for her to fight against the ventilator. Now, having said all of that, there are different schools of thoughts now coming up, and I encourage you to also check out Carly Dayton, who's one of my colleagues. I had Carly on my podcast. She's a nurse practitioner in the US, and she's talking about the walking ICU, where patients on ventilation with a breathing tube are not in an induced coma and with very good outcomes. So the question is, why is your wife so heavily sedated, and can they avoid that? And my advice is to try and get her to wake up as quickly as possible. There's also the risk that the longer someone stays in an induced coma, that the harder it is for them to wake up. And once again, the sooner someone can come out of an induced coma, the better. Also, when someone is in an induced coma, the side effects like deconditioning, wastage of muscles, etc., is real. So therefore, the sooner they can wake her up, get her out of the induced coma, the less the risk for any complications. So it's really important that they can wake her up as quickly as possible. A lot of patients don't wake up from an induced coma straight away. It's more like switching on a light with a dimmer rather than switching on a light with a switch. A lot of it also depends on what sedatives your wife is having. So, for example, propofol is a short-acting sedative, right? You give propofol, patients go to sleep pretty quickly, and when you switch it off, they should wake up pretty quickly. It's short-acting. Midazolam or Versed, on the other hand, is a benzodiazepine, and it is long-acting. Comes with many undesired side effects, including delay in waking up, including that benzodiazepines are addictive in nature. So that means if someone is on midazolam for a few days, their body might become addicted to it, and then they might go through withdrawal when waking up out of an induced coma, further complicating, the waking up process. Also, the other issue here is when patients are in an induced coma, whether propofol is being used, whether midazolam / Versed is being used, or whether Precedex is being used. I'll talk about Precedex in a minute, but often fentanyl or morphine is being used as well. Fentanyl or morphine are known as very strong opiates, very strong painkillers, and they come with undesired side effects as well, such as, they are sedative, they have a sedative effect as well. More importantly, one of their side effects is respiratory depression. And when someone is on a ventilator, you don't want to give drugs that have respiratory depression as a side effect, right? And you simply don't want that, And the sooner you can eliminate those medications, the better, right? similar to midazolam/Versed, morphine or fentanyl are addictive in nature, once again increasing the risk that by using them, that your wife will be going through withdrawal, and you don't want to go through withdrawal, if that makes sense, right? So, okay, so let's move on to the next question. And just as a side note, we also have a membership for families of critically ill patients in intensive care, because we get so many questions from families in intensive care. We can barely keep up. Like I said, this question from Billy goes as far back as October last year. That's how many questions I have sitting in my inbox, and we're just not getting to them. But if you become a member for our membership for families of critically ill patients in intensive care at intensivecarehotline.com, and you click on the membership link, or you go to intensivecaresupport.org directly, that's when we can help you faster. Because in the membership, you have access to me and my team in a membership area and via email, and we answer all questions intensive care related. You also have exclusive access to 21 ebooks, 21 videos that I've personally recorded and written. And that will help you to make informed decisions, have peace of mind, control, power, and influence. Next question from Natalie, who says, my mom is in ICU and I'm frustrated because the intensive care team is only giving us doom and gloom scenarios. How can we counteract that? Well, Natalie, thank you so much for reaching out with that question. The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's exactly your challenge. You don't know what you don't know. So here's what intensive care teams don't tell you. They don't tell you that 90% of intensive care patients survive. That means 9 out of 10 intensive care patients leave intensive care alive. 1 out of 10 is not surviving. Now, full disclosure, when patients leave intensive care alive, we don't know what their life and their quality of life looks like in 6 days' time, in 6 weeks' time, in 6 months' time, in 6 years' time. We don't know. One thing that we know for sure is that if a patient is going to die or is not getting best care and treatment and is potentially set up to die, we know the outcome there. We know that if we don't keep trying, we know that patients most likely will die, right? So the question is, which way do you want to go? And also, which narrative do you want to have in your head? You can adapt and embrace the doom and gloom narrative from the intensive care team. That's a choice you can make. Or you can create your own narrative and you can start talking about a positive narrative. The choice is yours. You can't control other people, but you are 100% in control how you react and what narrative that you want to create, right? Like I said to you, we have saved many lives here with intensive care hotline and intensive care at home, and you can verify that on our testimonial section just by changing the narrative and starting to talk about more positive things, right? So don't get dissuaded by doom and gloom. Don't get dissuaded by intensive care teams trying to make you feel guilty. You know, like I've done a YouTube live a few months ago with the title something to the effect of, what if the intensive care team is want to guilt trip you, right? Talking about intensive care teams trying to make you feel guilty, you know, when you want to keep going with treatment. Well, this is your family. This is not the intensive care team's family. Their job is to do what you want to have done to save your loved one's life, right? So create your own narrative, get help, get a second opinion, get help, get a second opinion, get a medical record review, which is something we do here at intensivecarehotline.com. get a medical record review, get us to talk to doctors and nurses directly. And that's pretty much it. You know, control what you can control, right? That is very, very important. And that leads me to my next question from Libby, who also has a short comment and says, people are talking, or the intensive care team is talking to us and my family as if my brother is going to die. Well, Libby, thank you for sharing this. Here's my response to that. Once again, 90% of intensive care patients survive. So why would your brother not be in the 90% bracket? That's number one. They would have to give you very good reasons that your brother is not in the 90% bracket, right? Next is this a real or a perceived end-of-life situation? So I have, when I first started blogging and making videos at intensivecarehotline.com, one of my earlier videos was starting to talk about, or making a video about, real versus perceived end-of-life situation. So, and I think with that email that you sent there, Libby, I think I need to highlight the difference once again. So what's the difference between a real and a perceived end-of-life situation? So a real end-of-life situation is a situation where a patient in intensive care is going to die, and it's inevitable. No surgery, no fancy equipment, no fancy medications, surgery, life-saving equipment is going to help. Your loved one is going to die, full stop. On the other hand, perceived end-of-life situations in intensive care are much more frequently than real end-of-life situations from my experience. Here is what I mean by that. When treatment is not being offered in intensive care, or potentially treatment is withdrawn, and you may not even know about it, because intensive care teams have ways to sometimes conceal that, right? That is a perceived end-of-life situation, because if you keep going, if you continue treatment, then your loved one is being kept alive, whether that's artificially or not, doesn't matter. So if you then withdraw treatment, and your loved one is going to die, that in my opinion is a perceived end-of-life situation. There's a big difference, and you need to find out what your loved one situation is. And once again, this is where a second opinion comes in. This is where consulting and advocacy is coming in. This is pretty much what we do. Like I said, we have saved so many lives by educating our clients, by empowering our clients, by asking all the right questions to intensive care teams, by asking all the questions that families haven't even considered asking, right? I'll give you an example. It was one of our earlier clients, more than 10 years ago, but I still vividly remember it, where the intensive care team said to the family, well, this man is definitely going to die, and there's nothing that can be done. So then we looked at medical records, we started talking to doctors and nurses, and then we found out, well, he's not going to die if treatment is being continued. And that's what's happened. We put the pressure on, and treatment was continuous, and this man left ICU a few weeks later, left ICU alive. So that's what I'm saying. You can't control what other people do or say, but you are 100% in control of what you do and say, right? Always keep that in mind. I hope that helps, Libby, to clarify your situation. Okay, now let's move on to the next question, which is from Bianca, who says, hi Patrick, all they can talk about is what date they want to take my husband off the ventilator. The palliative care people are all over me, putting pressure on me. Now I have decided I want to take my husband home. Well, Bianca, I think that's a very smart thing to do. And, it ties right in with what I just said a minute ago. You can't control other people. but now you are taking control and you're starting a different conversation, which I think is great. Start a different conversation and change the narrative, right? Now, but more importantly here, Bianca, you're saying your husband is on the ventilator. You haven't shared whether your husband is on the ventilator with a breathing tube or with a tracheostomy. You haven't shared why your husband is in ICU. If you want to take your husband home, then if he can't come off the ventilator, he will need a tracheostomy. Taking him home with a breathing tube is too risky. But if he has a tracheostomy and you want to take him home, that's absolutely possible, including if you want or your husband want palliative care at home. We've certainly done that with intensive care at home, palliative care at home for ventilation, tracheostomy, or for non-invasive ventilation such as BiPAP, CPAP, or palliative care for non-ventilated patients. So, but it's good that you are changing the conversation here and that you're not getting bogged down by the intensive care team narrative. You can create your own narrative. You stay in control of what you want to talk about. So if you want to take your husband home, I'll just encourage you to reach out to us at intensivecareathome.com. But again, it's also a case, like I said, this question is actually from the 1st of March this year. We get so many questions. So, if you want to have your question addressed in a video quicker, either reach out to us directly at intensivecarehotline.com, call us there, or send us an email to support@intensivecarehotline.com, or just make a small donation on the super chat button, and then I will get to your video as quickly as possible. But also anyone on this call, if you want to ask your questions in the chat pad now, or if you want to join me live on the StreamYard link here, just click on the link in the chat pad. I'm looking forward to your questions. In the meantime, just Bianca, if you want to take your husband home, some boxes need to be ticked. Your husband needs to be reasonably stable. There's a lot we can do at home with intensive care at home, but there's certainly more that I need to know before I can say whether we can take your husband home or not. In the meantime, just stop talking to palliative care. Just tell them you don't want to talk to them and that you expect everything to be done to keep your husband alive. It's no more difficult than that. ICUs are very good at pretending to let people know they can do whatever they want. They're very good at pretending that. Well, that stops the minute you start questioning. It stops the minute you start questioning their narrative, right? The sooner you question the narrative, the better, especially when things are not going your way, right? So, and if they keep talking about end of life, just let them know you don't want to talk about end of life. You want to talk about how can your husband live, right? So just change the narrative. Okay, let's move on to the next question, unless someone has a question here, wants to join me on the live stream, or wants to type the question in the chat pad. Please do that. If not, I will move along to the next question. Which comes from Tandy. And Tandy says, "Hi Patrick, they can't find the source of infection in my mother's lungs, which affects improving her lung function to get off the ventilator." Okay, Marion here says on the live stream, "I was never educated on anything but end of life. Why is this?" Yeah. From my extensive experience, Marion, it is because to number of things, number of dynamics at play here. ICU beds are in high demand. Okay, the most sought after bed in a hospital is the ICU bed, pretty much in line with the emergency department bed, emergency room bed. Okay, beds are in high demand. So that's one of the reasons why, if ICUs can stay in control of the narrative, i.e., if they, make you believe all that's happening here is end of life, that keeps your expectations low, right? And it doesn't expand your horizon about, well, what else can we do besides talking about end of life, right? It might stop you even from making your own research, right? Which is what they often want. They don't want you to go on Google and find my videos and educate you about what you need to know when you have a loved one in intensive care, right? So they don't want you to know that 90% of patients in intensive care survive. They want to make you believe that, there is a really high mortality in intensive care. That's what they want to make you believe, because then they can stay in control of the narrative, right? So that's one reason. But again, it is entirely up to you to create a different narrative. It's entirely up to you to learn about the difference between real versus perceived end-of-life situation, right? So here are other reasons why they want to talk about end of life and nothing else. The worst case scenario for an intensive care team is to look after someone indefinitely with an uncertain outcome. That is their worst case scenario, right? And many patients in intensive care, unfortunately, meet that worst case scenario from their point of view. Now, I don't know, Marion, what your situation is or was. It would be great if you can share more about what is happening to your family. The more insights, the better. So that's one of the many reasons why intensive care teams, focus on the end of life scenario, on the worst case scenario, and they want to make you feel guilty if you are even thinking on continuing treatment. I also think there is a, for lack of a better term, quote unquote, God complex, in terms of that many doctors and nurses think they know what's best, right? And I believe it's in God's hands. Of course, medicine has come a long way. And also, I'm well aware there's a lot of good things happening in ICU that I don't talk about as much as I should be talking about, because, I've worked in ICU for decades, and there's a lot of good things happening in ICU. The issue is that, the clients that are coming to us, there's not a lot of good things happening for them. So we are dealing with that 10% bracket here, where, it's often life or death. The other 90% are going out early out of ICU, and people move on with their lives, hopefully. Yeah, and it is, I'm glad you're saying that, Marion, that you're saying, I wish I saw you early. I get that. And there's so many families coming to us when it's too late. And I keep saying that you need to do research day one when you are in ICU. You can't leave it up to chance. You can't wait for a miracle to happen. And sometimes miracles do happen, but I wouldn't bet on it, and I would get help. Yeah, you just go to intensivecarehotline.com, Marion, and you can either write an email there to support@intensivecarehotline.com, or use the contact form on our website, or just give me a call on one of the numbers on the top of our website. If I don't answer straight away, leave a message and I'll get back to you. So, okay, Marion, thank you for your input here. So let's go back to Tandy's question, who said, hi, Patrick. My mother's in ICU. They can't find a source of infection which affects improving her lung function to get off the ventilator. Okay, so if your mom has a lung infection, a few things. They should be sending a sputum sample to find the source of infection, right? If they can't find the source of infection, the next step might be to do a bronchoscopy, right? A bronchoscopy is basically to put a video camera down in the lungs, suction off any infections, and send a sample there. Sometimes that might be the beta sample, right? That could be an option. Another option here could be to start some antibiotics, broadband spectrum antibiotics. So those are options here. But you are right in saying that if they can't improve the lung infection, that it will make it harder for your mom to get off the ventilator. That's why it's so important to find the right source of infection. Other things that can help in a situation like that is potentially prone positioning, basically head down and lying on the tummy, right? That can help as well to drain any excess secretions, right? But bronchoscopy might be the next step here, and obviously screening for the right antibiotic and the right bug. Okay. Now, next question, unless someone wants to type a question into the chat pad or wants to join me here live on the show, if you want to talk to me directly. If not, I'll move on to the next email. If you just want to listen in, that's fine as well. Let me get to the next question that has come in from Morgan. And Morgan says, hi, Patrick. Oh, 20, before I go, 20, please ask your questions. Even easier, just join me on the show here. Just use that link if you want to talk to me directly. That's the easiest way to get your questions answered most efficiently. Don't be shy, I don't bite. And you don't need to go on camera if you want to stay anonymous. There's no issue around that. So just join me on the stream here. You're more than welcome to ask as many questions as you like. I usually go for another half an hour. Please shoot away your questions. Even better if you join me on the stream here. In the meantime, I'll keep reading out the next question while I wait for either to join me here or type your question into the chat pad. Okay, question from Morgan. Hi Patrick, my mom is in an LTAC ICU after an emergent coronary artery bypass graft operation at the end of August, and they said her 30-day stay's up and we can either take her home with a ventilator or hospice. Before all of this, she had no prior health problems other than breast cancer 15 years ago. She had chemotherapy and radiation. She had complications during a cardiac catheter procedure, which resulted in a coronary dissection and cardiogenic shock, which is the reason for an emergent coronary artery bypass graft surgery. She had multiple complications post-operatively, including bleeding, heart failure, and 3 days of CRRT. CRRT stands for continuous renal replacement therapy, also known as hemofiltration or dialysis. Her kidney functions are close to normal now. She was on sedation for 14 out of 21 days in the ICU before going to LTAC. On admission to LTAC, and also for everyone, LTAC stands for Long-Term Acute Care Hospital, which is a very specific hospital to the US. There are no LTACs in other countries, but I will talk more about that in a minute. On admission to LTAC, we were told she had severe sepsis and 2 small strokes that were discovered once the CT was done at the LTAC ICU. She also had to get a tracheostomy during her stay in ICU, since she was unable to come off the ventilator before getting to LTAC. Okay, Twainy, I'll get you on. Hi, Twainy, can you hear me? I think you are on mute. Can you hear me, Twainy? Welcome, and please ask your questions. Oh, you're gone. Okay, I'll carry on with the question that I've been reading out, and I'll carry on there. Okay, I just need to get back to my emails. Okay, so On admission to LTAC, we were told she had severe sepsis on two small strokes that were discovered once the CT scan was done at the LTAC ICU. She also had to get a tracheostomy during her stay in ICU since she was unable to come off the ventilator before getting to LTAC. Since the coronary artery bypass graft surgery, her ejection fraction is 40%, but we are now being told she has metabolic encephalopathy since she's not consistently responsive. Let's try again. Twainy, can you hear me?
Yes, I can hear you. Perfect.
That's wonderful. That's wonderful. How can I help you, Twainy?
Yes, I've been watching a lot of your videos, and they're really awesome. I want to firstly say that I've been like watching a lot of them probably this whole week, and I was gonna set up a one-on-one, but then I was like, okay, let me get on the live stream. And I'm sorry, I'm getting wordy. So my mom was in the hospital starting last year in June, and she had renal failure for her kidneys prior to, so she got a new kidney around 15 years ago or so. And then recently she's had a liver failure, so they had to have a liver transplant June 6th of 2023. Now she's been in the hospital for literally the ICU this whole entire year, and it's been a very tough time for me and my family in regards to us, like, having to change up our whole overall lives. And she's been on the vent for a very long time as well. When she was in the hospital, she started off, everything was going fine. Maybe the first like month or so, everything was good. We were going to feel like she was going to go into recovery. Then she had twitching on the right side of her face, and we didn't know what was going on. And then all of a sudden, she had to be sedated very heavily, and then they figured out later on that she had a stroke. So that was the first thing. And then after that, they were trying to figure out how to get her back good. But then there was something going on with the brain. And also she was in serious depression. And then she started getting like dependent on the vent. And, now, fast forward, now we're in a position where, her liver is better, to be transparent. It's not at the same place it was. But then now it's so hard to get her off that vent. And every time we try to get off the vent and they try to take her off the vent for a decent amount of time, she's having the CO2 buildup, and then with the CO2 buildup, she can't tolerate it for a long time, and then she has to get back down to high vent settings, and then we start this whole thing over again. And then also she's been in there for a year, so she's prone to infections, and every time she gets an infection, then she gets like really sleepy. They have to put her like when she's very sleepy like that, she has no energy, she has no strength, she can't breathe down deeply, then her lungs are not strong enough. It's just like this whole long cycle, and it keeps on going. And each and every time, we're not that we're scared, but we're in a position where we don't know if she'll come out of infection if she is to have an infection again. Last week, because it was her first full year at being at the hospital, I don't know. The doctors came up to us and had a conversation with us, the liver team, as well as some of the ICU team, and let us know that they wanted to see about doing a couple things. And first step would be DNR, do not resuscitate, if it comes to that point. The second one was getting to a long-term facility. The third one was for her to go home, or go into quote unquote hospice. Now, a caveat to this whole overall situation: she's worked at this hospital for around 30 years or 35 years, and she was the head nurse of the emergency room. So I do believe that they are giving her great care, as well as I do believe that she's in a situation and position that they want to be on her side, quote unquote, because she's been in this hospital for so long and she's given her life to them, so on and so forth. But I also know that, they need to make money.
Yeah, yeah. 20, just one more question. Did you say kidney transplant or liver transplant?
Do you hear me now?
I can hear you. Yeah.
Okay, perfect.
Did you say kidney transplant or liver transplant?
So she had a kidney transplant how many years ago, Grandma? Around 15 years ago. She had a kidney transplant first. So the
Yeah.
renal failure runs in my family. My grandma had it as well as my mom. And she had it. So my grandma, yeah, a lot of family members have it. After that, I guess she had a cyst that was growing on the kidney and it was pushing down on the liver. So through that, she had to essentially be in a position where she needed a new liver, and it wasn't operating at full capacity. Grandma, is there I'm missing anything?
No.
Okay, yeah, I'm saying everything, I think.
Yeah, yeah. Okay, okay. I hear you. So, and she is still in ICU. She's got a tracheostomy.
She does have a tracheostomy as well, and she's in
Yeah,
ICU.
yeah. Where are you located, if I may ask?
We're located in Miami, Florida.
Miami.
Yeah, and the hospital she's at. I mean, I can say it out loud.
It's entirely up to you. You don't
Oh,
need to,
okay, yeah, yeah,
you
no,
know, you
it's
don't need to
yeah.
give anything away. The reason I asked for location is simply, is there a way for you to take her home? And that often comes down to the availability of services.
Yeah, and so I do believe that there's a now opening for us to take her home because the doctors are saying um that they would want us to make a decision, or they keep on like pushing us to say something, but they also are saying that they want to do their best to help her out in the position she's in. So there is a possibility of taking her home, but the issue is that we don't have the we don't have the wherewithal to make sure that she's going to be good because she's on the vent. Then on top of that, she could get infections, and on top of that, her CO2 goes up. I don't, you
Can,
know.
can you tell me a little bit more about why CO2 is going up? Do you know why?
Um, I'm get. Go ahead. Okay, I'm guessing that the CO2 is going up because like she's on the vent and she's not getting the opportunity to breathe in as deeply as possible. So it's like so I guess she's
Is
retaining
she
this. Yeah.
the first question that I have when CO2 is high is she potentially having, is there a history of asthma or COPD?
No,
So, did she have asthma, Grandma?
no, she didn't have it.
Okay, no, no,
She
CO.
got ill.
Okay. What about
Respiratory problem.
what about is she taking any opiates at the moment? Are they giving her any opiates such as morphine, fentanyl, oxycodone? Is she in pain?
Yes. So okay. So she was having pain, and she was having pain because she had a hematoma. So they had to do a liver biopsy. And she was about to go to rehab. When they did the liver biopsy, maybe 2 days before she was going to rehab, they pot they met. Something happened where like a vein was touched, and she had a lot of internal bleeding. With the internal bleeding, she had a huge hematoma, and they couldn't drain all of it, so it was in her stomach area. And with that being said, I think that put like some like a lot of extra months to her overall process. In all honesty,
Okay. How long ago was that?
um, it was late last year. Let's say is in December or
Okay.
Let's say January or February.
Okay.
The hematoma, Grandma.
Last,
Okay.
The
last
hematoma. The
year.
hematoma.
Yeah, last year.
When was it? Okay, it was maybe let's say January or February.
Not this
Okay.
year. Last
It's
year.
fine, Grandma. It's fine.
So as of right now, do you know if she's getting any opiates such as fentanyl, morphine, oxycodone, hydromorph? Have you heard of those medications?
I know that she was getting oxy at a certain point in time,
Yeah.
but she doesn't do it as much anymore. Um,
Okay.
because like not as much anymore. But I guess they give her, what do they give her now, Grandma? It's fine. Don't worry. I'm not sure specifically.
Okay. Because
Yeah.
because I would try and find that out, But the other question that I have is, do you know what ventilator settings she's on?
E-
I
it's
don't
not.
know
It's
because
not.
they changed
Yeah. They change.
recently.
Yeah, they change it all the time. She was on high vent settings. Now her pressure support maybe is at 8 or 10. It's not nothing high.
And
Um,
she's
Okay.
but it fluctuates. I think when she has the issues with with the CO2 rising, then she needs it more. And then when she doesn't, then like they're trying to wean her off. But they try to do it like multiple times. And when they're in the weaning process, the issue is that maybe they're weaning her too quickly, or they're trying to get her, like they're trying to make everything work out. Now they're trying to do a really slow process. So at certain points in time she was going 12 hours and 14 hours and 16 hours in a day, and we're so close to that 24-hour mark, but then all of a sudden she goes back to square one. And so now she's like at, let's say, like this week, I mean, they can't get her on TPs, in all honesty, TPN. And then maybe last week she was doing 4 hours, 5 hours a day.
Okay.
So
When you say, so she was off the ventilator on a trach mask.
She's not. She is sometimes. She's off the ventilator for a few hours.
hmm
So they call that what? Rest period. And she can breathe for herself, but after a while she has to go back on the vent.
Okay. But it's not, but basically what I'm hearing is there are periods where she's off the ventilator completely.
Yes, but she still has that trick.
Yeah, sure. But that's the first step to get off that
Yes.
ventilator. Once she's off the ventilator completely, that's when you can take the trach out. So that's,
Yes.
that is positive overall, even though it's, I understand it's been 12 months now, but that is positive that she does have time off the ventilator.
hmm
Are they getting her out of bed? Are they mobilizing her?
Yes, they take her out of bed every day and put her into the seat at least.
Chair.
The chair that's right next to her. We try to push for sunshine therapy as much as possible. Every time I'm there, I try to take her outside. Like I push for it, like a lot. And then also I try to move her limbs as much as I can. But she's really out of it every day, or sleeping, or very weak. So I mean, I push to put her legs up and her feet up, but physical therapy doesn't come maybe as much because she's not fully, like up. So
She's weak.
she's weak. So
This week, okay.
yeah.
She's got a PEG tube and she's getting nutrition through the PEG tube.
Yes, they actually, they put her in a peg tube. Yeah.
Is she losing weight overall, or is she gaining weight?
I guess she's stable now. It's like, just like
Stable.
the same weight now. I mean, at the
Okay.
beginning, she definitely did lose weight, but I like now it's just the same.
Right. Okay. Are they feeling positive that they can get your mom off the ventilator? Do you think they have a plan to get her off the ventilator?
That's a interesting question. I think that she's in the gray area. What they told us last week, and they say that she can. I mean, if another doctor came in that's outside the hospital and looked at my mom, they would say, "What are you guys doing? You guys might be fighting too much, and there's nothing that can be done at this point in time. You guys are taking it too far." But then also, there's times that she has some positives in in what's going on, and they see that there's somewhat of a path to her getting better and getting out of the hospital. So it's like they said she's in a gray area, and they could see how she can get better. They could see how with infection it could just knock her out really quickly. She's been fighting a lot of infections. She's also been fighting just to with all the other things that have happened to her in regards to the stroke and the hematoma and the botched liver biopsy. So it's just all these things that are happening, and it's a series of unfortunate events. And she also messed up her foot while she was in hospital because she fell as well. So
How does the stroke show up? Is she having a one-sided weakness?
yeah, so let's see, I mean, is it the left side or the right side? It's the right side of her body. The right side of her body. It's so at the beginning, the right side of her face was twitching, and I seen it, and it was a lot of twitching. So at that point in time, and this is like months ago, maybe now 10 months ago, then all of this out of sudden they sedated her for maybe 2 weeks or so. And then when she came out of it, just the right side of her face was really twitching. She was out of it every day, and the right like her right side of her body wasn't as strong anymore. She can't really raise it. She can't really raise her foot. I could noticeably see the differences when I was doing the exercises with her in the bed. She couldn't really push the right side down as much as she could as possible, and so on and so forth.
What about her cognition? Has that suffered from the stroke?
Yeah. So okay. Well, let me even talk a little bit more about the right side of her body. So at that point in time, with the twitching, they had to see about seizures, and they were giving her Ativan when they felt like twitching was a little bit much, and she could possibly go into a seize, because there were some times when she would just like possibly like stop, and we would just get scared. So neurology came down, and they were trying to figure out a lot of different things in regards to making sure her mental status was there, and she wasn't necessarily fully there mentally. So we had to do a lot of EEGs to make sure. But they said that she wasn't seizing when they were doing the EEGs. But they also said that she's extremely depressed, as well as she wasn't, with being in the hospital so long. I don't think she was fully here with us for some time. I think right now she's at a more sustainable place, but she's been crying like a lot, like every single day. It's like a lot of crying every time she opens her eyes. It's insane amounts of crying. It's really draining, to be transparent. And we go every day and we try to be a rock for her as much as we possibly can, but it can be a lot at times. And but she is crying a lot, and she's saying that she wants to go home, but then we don't know if I don't know what the best alternative is, and
Yeah,
you know
yeah, 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 yeah. Do you know if someone has done a swallow assessment with her?
Yeah, so they actually did do a swallow assessment with her. What was it? A month and a half ago, they were trying to get her on it, and they were trying to start her back on liquids, or maybe 2 months ago now. So they did it, and she didn't. What they call it? When they did the swallow test, Grandma, and she was not aspirating. She wasn't. Is that the word?
Yeah, but
Aspirating, yeah.
Yeah, aspirating. Yeah, they checked her off to swallow and whatnot. But then, right as they were doing that and giving her the opportunity to do liquids, she took steps back again, and she had to get off of that. And that's the tough part, because every time we go forward, then we go back.
So she didn't pass the swallow test at the time.
No, she did pass the follow.
Okay.
She did pass the swallow test, but then
Uh,
when she got off of
yeah.
it, then she went backwards.
Okay. The reason I'm asking for the swallow test in particular is, so let's just wave a magic wand for a minute and say she comes off the ventilator, right? Then the next step is to remove the tracheostomy. Now, the tracheostomy can only be removed if certain boxes are ticked. One of those
Yeah.
boxes that needs to be ticked is to pass a swallow assessment,
Yes.
right? So, with all of that said, if she can come off the ventilator, it sounds to me like she has a chance to maybe have the tracheostomy removed because she has passed the swallow assessment at some point, right? So I'm just
Yeah.
trying to think ahead, if she can stay on that path of getting weaned off the ventilator, is it realistic for her to also have the tracheostomy removed at some point? With what you are sharing with me, I think it is within the realm of possibility. That's
Yeah.
assuming she can, keep getting stronger,
Mm-hmm.
and it breaks my heart, listening to you that she's in there crying every day.
Yeah.
Like I know there's no quality of life in an environment like that.
No.
It's just terrible. And if it's been 12 months now, it's probably time would be ideal to get her home.
Yeah.
By the same token, it has to be safe.
Mm-hmm. Mm-hmm.
It has to be safe, and you have to find someone in Miami who can help you to get her home safely. And lo and behold, she will need 24-hour intensive care nurses at home to make that happen, as
Yeah.
long as she has the ventilator or a tracheostomy or both, right?
Yeah.
If she can be weaned off both, she won't need ICU nurses at home.
Mm-hmm.
She will need a different level of care. But as long as she has a ventilator and or a tracheostomy, she will need ICU nurses 24 hours a day. Otherwise, it won't be safe.
Yeah. Yeah. Yeah.
Just one more question. She's not on dialysis, is she?
yeah.
Yes, she is now.
She is.
Yeah. So they do it every day. Now she wasn't doing. She was. They got her off of dialysis. And her kidneys were coming back fully. They came back fully, but then when they did the liver biopsy,
One kid.
and not both kidneys. Well, one kidney came back, and when they were doing the liver biopsy, it really messed up the kidney, and I don't know if it's going to knock back on again now, to be honest.
Right.
And they wouldn't be able to do any level of transplant because their body is just too weak on
Yeah,
all.
no, that would be very difficult.
Yeah.
Are they pushing you? Do you think like they're pushing you towards palliative care and end of life care?
Not really.
Not fully. Not fully. I think they're pushing us towards. They're not fully. I think that they're pushing us towards it seems like they're even with it. You go into long-term facility or you go home.
Depends which doctor.
Yeah, and again, okay,
Yeah.
good. Yeah, it depends on which doctor, because the ICU team might have a perspective. The liver team, they worked really hard on getting her through it, but then the issue is that you know she's just been there for a very long time. So I think those both teams have maybe possibly different perspectives. Liver team maybe also wants her
Yeah.
to go to another facility. I don't know.
She
Yeah.
looks
No,
like
I'm not.
she looks like she could heal, but everything is taking a long time.
Yeah.
Like it's over a year now, but it's not the same problem every day. Every time that something happens, it sets her back. However, I I should have checked this out because they told me that she's now on SIMV,
Yeah. Yeah.
and honestly, I don't remember what it does, but I think it's the area that helps her breathing.
If she's in SIMB now, it
Yeah.
means that the machine is pretty much doing all the work.
Oh.
Yeah. SIB pretty much means she gets a rate from the machine every minute. That could be 10, it could be 12, it could be 20,
Uh-huh.
whatever they deem. I would actually say it's probably more towards the 20 side because her CO2 is high,
Yes.
right? Which, I would say with what you've shared with me earlier, that she had time off the ventilator a few weeks ago. If
Hmm.
she's now in SIMV, I would say that makes it less likely for her to be weaned off the ventilator. When
Wow.
was the last time she was off the ventilator completely? Do you know?
The last time she was off the ventilator completely was last week, I'll say,
Okay.
and
All right.
maybe we were trying to get her up to 5 hours with the because I speak to the respiratory therapist every day, and they come in and they see if there's an order in for her to be on off the ventilator on the TPs, and then she also has the voice thing, and she doesn't speak as much
Just
now.
speak. Yeah.
Yeah.
Look, something might have changed between last week and now. Maybe her CO2 has gone up, which is why they're putting her back on SIMV. I don't know. I would need to look at the medical records or talk to
Hmm.
someone directly, but that would be my estimate here,
Hmm.
right? Let's just wave a magic wand and you wanted her at home. Again, I don't know how much research you've done. We are also providing a service intensive care at home, not in Miami at the moment. We could potentially help you privately, with
Okay.
private nurses, but you would have to pay out of pocket. That would be very expensive, of course.
Yeah.
But I'm not aware of a provider in Miami that can take someone home on a ventilator as complex as your mom. I'm not aware of it. We could do it, but
Yeah.
it would be privately, if that makes sense.
No, that makes total sense. That makes total sense.
But in terms of getting her home logistically, I argue it's doable. You know, and the sooner she can go home, probably the more she will improve. Just simply from on a psychological level, she's
Uh-huh.
literally desperate to go home.
But then my only question is, if we take her home, because it wouldn't be a situation where I wouldn't want to take her home, but is that, because I'm also looking at her quality of life, and I don't believe that her being in the hospital is the best thing, to be honest. She just looks up in the air and she doesn't really want to watch anything anymore. It's like the same old stuff. And I know she doesn't want to be there. My only thing is, if we take her home, are we putting her at a disservice as well, and possibly, not being able to take care of her in the highest way possible? Is my only question.
Yep. So the challenges that I can see with home care is, if you set it up with 24-hour ICU nurses and you set it up with an RT coming, and the doctor overseeing it, pretty much everything they're doing there at the moment can be done at home, right?
Gotcha.
The only exception to that is if she requires vasopressors or inotropes like epinephrine, norepinephrine, vasopressin. Do you know if she's on any of that?
Grandma.
She's not on any of those medications permanently,
Okay.
but when she needs pain medication, I can't remember. Sometimes she gets dilaudid.
Yeah, she gets that.
Dilaudid, yeah. Dilaudid is just a pain medication. I'm more about the medications that I just mentioned, epinephrine,
No.
norepinephrine, they're life support. They're considered life support for low blood pressure. If she doesn't have them, I argue she's stable enough to go home with the
Okay.
right level of support.
Yeah. Okay. That's positive reassurance. Okay. Now, my last thing, I don't want to. I know you're only an hour, but if I wanted to actually have a follow up with you, is that possible as well?
Of course, absolutely. Just contact me. Either send me an email to support@intensivecarehotline.com or just call me on one of the numbers on the top of the website, intensivecarehotline.com.
Awesome. And
Right.
and your services are not in Miami either.
Well, not yet. However, what we are good at is we are hiring nurses in different locations. For
Gotcha.
us, it really comes down on putting up a job ad and finding nurses, really, and we are good at that.
Gotcha. Okay. I really, really appreciate you taking the time to listen to my story, as well as you answering all the questions, because it was really appreciated.
It's a great pleasure, Twainy. I hope it all goes well, and feel free to reach out to me anytime.
Awesome. Thank you, Patrick.
It's a great pleasure. All the best to you and your family. All the best.
Right. Ciao.
Thank you. Bye.
Bye.
Thank you so much, Twainy. I do want to wrap this up now, and thank you for everyone joining this live stream, and thank you everyone for watching this on the replay. I do these YouTube lives every week, 10:30 a.m. Sunday, Sydney, Melbourne time, 8:30 p.m. US Eastern Standard Time on a Saturday evening, which is 5:30 p.m. Pacific time. Now, like I said, I also offer one-on-one consulting and advocacy. Please reach out to me directly at intensivecarehotline.com. I talk to you and your families directly. I talk to doctors and nurses directly. Like I said, we also have an online membership for families of critically ill patients in intensive care. You can get access to the membership at intensivecarehotline.com if you click on the membership link. Like I said, we also provide intensive care at home services in different locations, currently predominantly all around Australia, but also in US and UK. So please reach out to us there as well. We provide NDIS support coordination in Australia, level 2 and level 3. And if you like my video, subscribe to my YouTube channel. We also offer we also offer medical record reviews in real time and medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website or send an email to support@intensivecarehotline.com. Once again, subscribe to my YouTube channel, click the like button, click the notification bell, share the video with your friends and families, comment below what you want to see next, what questions and insights you have. If you want to make a small donation to the super chat, I'll get to your video as quickly as possible if you want to have one done. It helps us to create as much content as possible for families in intensive care. And also check out intensivecareathome.com for if you want critical care nurses in your home all around Australia or in the US or in the UK. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I'll see you again during the week. Take care.